Hi, everyone. My name is Tammy Carr, and I'm a co-founder of the ChadTough Foundation, and otherwise known as Chad's mom. We're excited to bring you an informative session today that will be for both of our supporters, as well as families who are currently in the fight against DIPG. The ChadTough Foundation, along with Defeat DIPG, our partner, are thrilled to bring to you three incredible researchers who we support: Sabine Mueller, Cynthia Hawkins, and Michelle Monje. They're going to be sharing about current research in the field of DIPG, as well as upcoming trials that you can expect to see in 2021. Moderating this discussion is one of our board advisors from the University of Michigan, Carl Koschmann. So we're very thrilled to have everyone here today, and we hope this will be helpful to all of you out there who are currently in the fight. And to our supporters, we hope this will help you to see the research that you are helping to make possible. Thanks, and take it away, Carl.
Hello, everyone. I would like to welcome you to this ChadTough Foundation virtual web discussion. This is an event that is hosted by the ChadTough Foundation, and I am serving in my role as a scientific advisor to the foundation. I'm happy to host some of the biggest names in research in DIPG and DMG. And our goal here today is to cover the clinical care, clinical research, and promising future research steps for DIPG and DMG in a way that will be hopefully understandable to the lay community, and not necessarily just for other researchers, although may be useful for other researchers as well. And our plan will be to share this as widely as possible, and hopefully it will prove helpful to family members. We structured this discussion topics around the questions that come up often, to me, at least as a pediatric neuro-oncologist when I see patients with DIPG or DMG. But we also wanted to make sure that we covered some of the latest promising research that some families may not even be aware of. So I will just start by introducing myself, and then we'll go around and you can meet the other members of our panel. My name is Carl Kashman. I'm a pediatric neuro-oncologist at the University of Michigan, and I also have a lab. And my clinical and research interests are in pediatric high-grade glioma, and specifically DIPG and DMG. I will next move on to Cynthia Hawkins from SickKids, and then Michelle Monje from Stanford, and followed by Sabine Mueller from Zurich and UCSF. And I'll just let you guys go in order and introduce yourselves.
Hi, I'm Cynthia Hawkins. I'm a neuropathologist at the Hospital for Sick Children in Toronto, and a professor at the University of Toronto. My clinical focus is on pediatric brain tumor diagnosis, and I have a research lab on also pediatric high-grade glioma, in particular DIPG.
My name is Michelle Monje. I'm a pediatric neuro-oncologist at Stanford University, and I run a research laboratory focused on pediatric high-grade glioma, in particular diffuse intrinsic pontine glioma and other similar diffuse midline gliomas. We seek to understand exactly how these emerge in the developing nervous system and how we can best treat them.
I'm Sabine Mueller, also a pediatric neuro-oncologist, being at UCSF and also leading the Diffuse Midline Glioma Center in Zurich. And really my main research interest is developing new innovative trials for children with DIPG, and also have a laboratory effort at UCSF developing such new therapies.
Great. Thank you, everyone. And we're really excited to have this group. We are going to start, our first part will be to cover the current state of clinical care for DIPG and DMG, and then how these tumors are diagnosed and treated, what is established treatments, and what are the current prognoses and outcomes. And then we'll move on in the second part to current clinical research efforts. So I want to start by addressing the question to Cynthia Hawkins in regards to the acronyms DIPG and DMG, and the importance of the histone mutation, and then just broadly how those terms and molecular attributes affect diagnosis and prognosis.
Okay, so this is a bit of a confusing topic and probably will be a little bit more confusing when the next WHO classification comes out. So DIPG, which is diffuse intrinsic pontine glioma, I think of that as a clinical radiologic diagnosis. So if you have characteristic clinical presentation, which you guys can expound about, and classic imaging features, then you get a diagnosis of DIPG pretty much, I think, irrespective of what the pathology looks like or what the molecular ends up being. Once we sort of began to do more biopsies on these tumors and we knew a little bit more about the molecular, it became clear that a large percentage of these had histone mutations, which I think everyone is very familiar with now. And so this H3K27M mutation became highly associated with DIPG, although I think not every single DIPG has that mutation. I think that's clear. Then as we began to understand more, we realized that that histone mutation can also be found in gliomas outside of the pons, so including the thalamus and the spinal cord, as well as other midline locations. And that's what led to the introduction of the term diffuse midline glioma, to kind of acknowledge the fact that it's not just the pons that those histones mutation arise in, but also these other locations. And so in the last World Health Organization classification, the term diffuse midline glioma, or DMG, was introduced, DMG H3K27M mutant. Upcoming classification will acknowledge the fact that we now understand that not every one of the cases where there's an alteration in that histone K27 mark is associated with an actual K27M mutation. So these other variants are quite a bit rarer, but they do exist. So you can have rarely the situation where instead of an M, you have an I. And so the new sort of umbrella term for these is going to be DMG H3K27 altered, which means you won't have to have an M. And the other group that includes then are tumors that have a loss of the K27 trimethylation, so sometimes written as ME3. But don't necessarily have an actual mutation at that lysine residue. And those tumors often will have overexpression of another protein called EZIP. So you'll see in the upcoming 5th edition of the WHO CNS tumor classification that the overall term DMG H3K27 altered, with different subgroups related to which actual histone is mutated, the 3.3 or the 3.1, and then also acknowledging the third group where there isn't actually a mutation. So I don't know if that's clear enough.
That's good. Just as we had a handle on these acronyms, the WHO keeps us on our toes. So I want to move to this decision to biopsy, and a lot of families struggle with this decision. And I want to address this question to Michelle Monje in terms of when you talk to your patients, what you say in terms of the risk, benefits, and current trends, and then if you can touch on how you feel about or what the practice might be about rebiopsying these patients.
So, as many people listening to this webinar know far too well, DIPG presents with a pretty classic triad of symptoms. So kids and young adults often present with a 6th nerve palsy, one eye turning in or both eyes turning in, weakness on one or both sides of the face or body, and some clumsiness. And when children present with that kind of classic presentation, usually there's a relatively short history. And when we do imaging, we see a classic, diffuse involvement of the ventral pons. The diagnosis can be made clinically at that point. But there's a lot of information that is missing when we make that diagnosis clinically. We don't know, the details that Dr. Hawkins was just discussing, if there's a mutation, which mutation, what other mutations might travel together with that mutation that could potentially be targetable as we learn more. And then, of course, there are children who don't present with the clinical, with a classic clinical presentation. Perhaps the symptoms have been going on for longer. Perhaps the symptoms were a little bit different, or maybe the MRI appearance isn't that classical, diffuse, symmetrical involvement of the ventral brainstem. Perhaps things are a little bit more to one side or the other, or not involving, the 60% or more of the pons. And in those cases of atypical DIPG, or in the case that increasingly we have clinical trials that are targeting, different molecular alterations that we need to, really understand in a granular way, then we recommend a stereotactic biopsy. And stereotactic biopsies have been shown in multiple studies now to be relatively safe in experienced hands. And so what I counsel my patients is that, biopsy can be done safely. It usually is done safely, but it has to be done at a center expert in performing these biopsies, and by a surgeon who has a great deal of experience.
Thank you. That's very helpful. In terms of the workup, so we talked about finding out whether the tumor is a glioma and then finding out whether there's a histone mutation. But what about some other terms that families may hear that are done at some centers, but not necessarily all? The decision, once you have the biopsy, to perform sequencing and also methylation sequencing. And also, could you touch briefly on the current and future state of liquid biopsy? And I'm going to address this to Cynthia Hawkins.
I think sequencing, as Dr. Monje was mentioning, is helpful if you can find alterations that may potentially help to guide the therapy. So some of the alterations can be found without doing extensive sequencing. Depending on your site, there may be small panels that people do that may be aimed at finding the alterations that are most readily clinically actionable. So it doesn't necessarily mean that if you didn't get whole genome sequencing, that your center is not providing you with sort of best care. So the amount of sequencing you get is site dependent and not necessarily influencing, the type of care that you're going to get access to. Methylation arrays for diffuse midline gliomas, I don't think have a huge role unless there's a real diagnostic dilemma that won't provide you with the mutation information that you might need to enter in particular trials or for targeted agents. It may be helpful if the diagnosis is in question. I think for this particular entity, that's not often the case. And it should be acknowledged that some of these alterations can be found without using next generation sequencing. So, histone mutations, for example, can be found using something as simple as immunohistochemistry. So the exact workup is going to vary from center to center. And, certainly I think your neuro-oncologist and the local pathology department can help guide people through that process of what's the best amount or the most amount of sequencing that may be helpful in their particular case. With respect to liquid biopsy, for me, that's very exciting. I think technology that is, slowly going to work its way into actual clinical service. So, and for this particular tumor, I think particularly exciting, because if we sort of reach the promise of that, which is that you can get a CSF sample and actually find all of the mutations that you might have found by doing a biopsy, then I think it's even safer than doing a biopsy to get that information. And, there's some evidence that if we take heterogeneity of tumors into account, that you may actually even find more alterations with a liquid biopsy than you may have found using a targeted small needle core biopsy. So personally, I'm very excited about that. And it's something we're really trying to push at SickKids in terms of developing that as a technology that we'll be able to offer to our patients.
Very cool. Okay, so we're going to move on next to just the standard of care therapy for a DIPG or a DMG, which is to pursue radiation, which is recommended at all centers. I want to address to Sabine Mueller the question of whether there's an importance of proton versus photon radiation for these tumors, which is a question I'm asked often. And then also to address the idea of reirradiation, whether that is increasingly a standard of care, and the use during radiation or outside of radiation of Avastin, just what your practice is and what you counsel patients.
Yeah, so thank you, Carl. So we had a lot of discussions about the proton versus photon. I mean, Zurich is one of the oldest proton centers actually for children in Europe, at least. And right now, our practice is not to recommend it. It's definitely not wrong to use proton therapy. And I mean, depending, especially when we're talking about these pontine tumors, I think our current standard is to recommend standard radiation therapy. If your center has protons available, then I think it's reasonable to it. I don't recommend to my families to travel to a site for proton therapy because right now it's unclear if that provides any real benefit. So I think if it's accessible and it doesn't cause additional strenuous travel for families, I think it's okay, but there's no clear recommendation from our point that we would specifically recommend proton versus photon therapies. That might depend for some specific DMG, depending on the location. That recommendation might be slightly different, but overall, I think it's basically fine, whatever type of radiation therapy you're getting. I think one key to remember, and that's very similar, I think, to what Dr. Monje had said in terms of a biopsy. We consider biopsy really now standard of care. The same with radiation. I think it's just really important that pediatric patients are being really treated by a pediatric radiation oncologist and to make sure the child is being treated in a dedicated center for that. When it comes to reirradiation, that's obviously something that has been reintroduced over the last years, really, that we are now using pretty consistently and pretty much, I mean, I see many of my colleagues, including myself, recommending reirradiation and their sign of progression. And I think the early data would support that it definitely prolongs survival. But I think we are learning now that maybe that strategy is really not for everyone. And I think we are learning also that depending on really the specific alteration in each child's tumors, that might be a really reasonable strategy and might not be. And so I do think that is worth a discussion and might not be really for every child, but for the children who did respond, we've seen good tolerability. And that was obviously a concern. Is it safe to do a second round of radiation? But what we learned, it's really safe. When it comes to Avastin, I don't use it prophylactically. So trying to prevent some of the radiation changes we see often in these tumors. I have been using it more and more at the end of radiation therapy when children do get into trouble and we sort of see this quote unquote pseudo progression, or when you're just finishing radiation therapy and we see significant alterations and are causing symptoms. But our recommendation at this point is also not to use it prophylactically.
Great, thank you. Okay, we are going to move on now. So that everything we've discussed so far is working up these tumors as well as the current standard of care, which is radiation and increasingly reirradiation. And now we're going to move to current experimental therapies. And I guess what we didn't touch on, and I guess I'll just mention now, is that the current prognosis for patients with DIPG and DMG is it carries a very tough prognosis, and there are few survivors beyond 2 years. What we know is that when these tumors carry the histone mutation, that tends to carry an even tougher prognosis and shorter time to progression and mortality historically. I think it's important that that families are aware of the sort of battle that is up against them. And there have been a lot of clinical trials that have not improved these outcomes. I think what all of the panelists would agree is that the current portfolio of trials that are available for these patients is not only broader and using new whole genres of therapy, we'll discuss these, is more promising than these trials have ever been. And I think all of us have started to see sort of cracks in the armor of DMG, and we're hopeful that we're right on the cusp of breaking this thing open. And so we want to focus a fair amount of time on these clinical trials, many of which were developed by the panelists here. And just really to provide a quick insight as to where the concept came from and sort of where we're at with the clinical trial. And then also where families could find availability of these trials. And so I want to start with Michelle and a couple trials that have come out of projects in her lab or in collaborating labs with hers that are both in trial right now. And I'll start with a trial with the targeted inhibitor INCB7839. And so, and then we'll move on to another, but can we start with that one, Michelle?
Yeah, and maybe I could take a step back and just say that, broadly, we think that, therapy for DIPG and other DMGs is going to rely on, number one, targeting the cell intrinsic vulnerabilities of the cancer cells. Number two, targeting the factors in the brain that the tumors are using to grow. So there are some critical microenvironmental interactions that are driving the growth of these cancers, and we're just beginning to understand those. But they represent an additional set of therapeutic targets that we can and hopefully will be able to effectively hit. And then third, leveraging the power of the immune system to fight these cancers and immunotherapy-based strategies. And so the first trial, Carl, that you are asking me to discuss is this, aptly named INCB7839. Just easy to remember and rolls off the tongue. So let me take one more step back and say that among the microenvironmental interactions that the DIPG cells are really deriving powerful signals from in the brain are the interactions with neurons. And we've discovered that neuronal activity very robustly drives the progression of DIPG, other DMGs, and other kinds of high-grade gliomas. And this makes some sense because we know that neuronal activity is one of the most powerful mechanisms that drive normal brain development and plasticity. And really, these tumors are taking advantage of that. And so as we've studied the way that happens, there's really two big categories of ways in which neuronal activity is helping to promote the progression of DIPG, or the ways that DIPG is taking advantage of activity in the brain. And one is through secreted growth factors, and the other is actually through electrochemical communication through actual synapses that form between the neurons and DIPG cells. And one of the key growth factors that we've discovered is helping to promote DIPG progression, and actually also helps to promote the formation of those neuron glioma synapses, is a molecule called neuroligin-3, which gets released in an activity-dependent way through the activity of an enzyme that's called ADAM10. And this molecule, this potential therapeutic, INCB7839, is a small molecule drug that inhibits ADAM10 and therefore prevents the release of this growth factor neuroligin-3 into the tumor microenvironment. And so in preclinical models, this was pretty effective at really slowing DIPG growth and halting progression. And so we're hopeful that children with DIPG may glean the same kind of benefit. Of course, this is going to ultimately be a strategy that we feel we need to combine with other ways to eradicate the tumor. But this is a clinical trial we've just opened within Pediatric Brain Tumor Consortium institutions to establish, the safety and recommended dose of this medicine to bring forward. And so this is an open trial across the country, and I'm hopeful that it's one that we can develop further.
Great.
The next, should I just go on to panovinostat marizumab, or you want to?
Please do.
Okay, so targeting cell intrinsic vulnerabilities, and I think several of us will speak to this, have been informed both by, kind of hypothesis driven, let's test this drug, this might really impair DIPG progression, as well as sort of broad drug screening. And so a collaborative effort between my laboratory, Kathy Warren, and Craig Thomas at the NIH employed patient-derived, cell cultures of DIPG and other DMGs, these patient-derived resources have been absolutely fundamental to discovering new potential therapies. And a very large drug library present at the NIH. And so with this, we screened 9,000 drug-drug combinations. And this work really built upon an earlier screening effort that many people in the field, including I think everybody on this call, contributed to, that had initially identified an epigenetic modifying agent, histone deacetylase inhibitor called panabinostat, as a potential therapeutic. And we've been working for the last several years to establish a safe dosing regimen and best tolerated regimen for panabinostat. So panabinostat, together with a medicine called marizumab, which is a proteasome inhibitor, came out of this 9,000 drug-drug combination screen as one of the more promising combinations. And so that trial is just now opening, led by Kathy Warren, together with myself at 6 institutions across the United States as part of the DIPG All-In Initiative consortium. And then Dr. Koschmann and Mueller, I would love to hear more about another combination kind of along the same vein and targeting those cell intrinsic vulnerabilities, ONC201 and GDC0084.
Yeah, so maybe Sabine, I can start by talking a little bit about ONC201, and then if you could talk about GDC0084 and the potential combination of those two. So ONC201 is a dopamine receptor DRD2 antagonist. So it's actually a drug that's closest in class to an antipsychotic. And yet, as far as we know, this drug doesn't have any impact, psychiatric impacts. But what it does do is for some tumor cell types, and this is pretty broad across a lot of different tumor cell types, it antagonizes DRD2, and that leads to what's called this intrinsic stress response in some tumor cells and leads to the cells dying. The promising part about ONC201 is that it's taken by mouth and goes into the brain. It's very good blood-brain barrier penetration. And it was not, as Michelle pointed out, it was not hypothesis-driven that this would work particularly well in histone mutant cells. And the jury is still out as to whether it does. What was found out sort of inadvertently was that in adult patients with GBM, the drug was tolerated well and the drug got into the brain well, but it was not very effective in that population. There were a couple of younger patients who did have the histone mutation who did a little better than expected. And so Sharon Gardner opened a trial at multiple institutions with the compound just in children with H3K27M tumors, including DIPG. And that study, the phase 1 of that is closing. And we're just starting to look at the results, but there are some subgroups that appear to be doing better than expected. And we really need a phase 2 trial to confirm that that's the case. And so work that Sabine Mueller has led and that I've taken part of is to look at combinations with ONC201, both preclinically, and then the goal will be to open up a phase 2 trial of ONC201 in combination with other drugs. So I'll pass it to you, Sabine.
Thank you, Carl. So we are excited for ONC201 given the favorable side effect profile, and I think we can build on this to then integrate it in potential combination strategies. And I think what we also learned from the initial mechanism, thinking that it's mainly acting through this integrated stress response, we also realize now that ONC201, but other compounds within the same class of agent, is really also significantly inhibiting sort of the energy metabolism of these DMG cells, which I think is our vulnerability. We are really trying to explore for therapies. And so one of the combination therapies we will discuss here today is GDC0084, also paxilosib, which is a PI3 kinase mTOR inhibitor. And, we have tried using these type of inhibitors because we know that this is a very important signaling pathways including adult glioblastoma, but we always struggled finding any efficacy because of poor blood-brain barrier penetration. Carl, what you mentioned is sort of a nice added value of ONC201 that it really gets into the brain well. And based on some of our preclinical studies looking at mice, but also looking at data from adult patients with brain tumors, we know that this inhibitor actually gets quite it's passing the blood-brain barrier quite well. And in our preclinical models, and we really try to validate this, the goal within our program was really to try to test this in multiple cell sources, really within multiple laboratories around the globe. And it really includes laboratories in Europe, in Australia, as well as in the US to look at this potential combination. And it looks very promising. And so we were lucky to get approval from both companies, because they're both not approved agents yet, to actually move forward as part of a clinical trial that we developed as the program that Carl alluded to, which we call DMG Act, where we are trying to really develop these combination therapies. And then hopefully at one point, once we establish some early signs, to also sequence different therapies so that we can react to the clinical status of a patient, but also to the imaging we see. But we are very excited about this combination to move this forward into our upcoming trial.
Yeah, so just to clarify, as of this fall 2020, the phase 1 of UNC201 is winding down. There's just a few slots left. And then the compassionate use program is slated to open up for the end of 2020 for single agent UNC201. And then the plan is to open up UNC201 in combination through PNOC, through the DMG Act in early 2021 at the multiple sites internationally. And so let's move on to a different class, which is this combination of infusing therapies directly through convection enhanced delivery. And Sabine, I'll bring this back to you just to maybe broadly update us on where we're at with this and where you think this may be, what trials are open now, and where you think this might be used in future clinical trials.
Yeah, I think to take a step back, basically why we think that many agents that looked so promising in our preclinical models and cured our mice maybe didn't show the same results in our patient is really that issue that these diffuse midline gliomas have an intact blood-brain barrier. So any medication you either give by mouth or through veins barely reach the tumor cells. And if they do at a concentration that most likely is not effective. And otherwise, if you increase the dose you give to these children, they experience significant side effects. So one approach, and this is actually not a really new technology, this has been around now for several years, is using something what we call convection enhanced delivery, where you basically put catheters directly into these brainstem tumors. And there are two systems. One is basically the brain lab system, which we are using in the United States, where children come in, you place the catheter, you infuse your agents of choice, and then you have to remove the catheter because these catheters are not approved to stay in the brain of these children. But then you have the European system where actually you implant up to 4 catheters really around the brainstem, and you have a little port coming out, and that system actually stays within the patient. So it's actually a nice system for repeated infusion. So depending what you're aiming to infuse, both of these systems have their pros and cons. And we recently, obviously, a couple of years ago, Mark Sudame from MSK published his great study using convection enhanced delivery, using a radiolabeled antibody that looked very promising and also showed that obviously this is a fairly safe method. And this trial will now move on from a single institution to a multi-site study, really, I think, within Europe and the United States. So that's really exciting. We have been working on using the single catheter placement through our PNOC consortium, mainly at UCSF, and trying to open up other sites using a liquid formulation of panobinostat, really to see, because we were so excited, obviously, about the data from Michelle, but how could we increase the concentration? And so that study with phase 1 is also coming to an end, and the data is maturing, but at least we can say that it's safe, and it's also safe to do this actually repeatedly. And then we're using another agent that has longer half-life, which is liposomal irinotecan. And I think I really see this methodology because it's really not for every child. The tumor has to really stay within a certain area because you cannot cover, if a tumor extending too much up or down from the pons, it's really hard to get coverage. But it will also depend, obviously, of what type of agent. So I see this for these really pontine-located tumors, like as a great step as part of the therapy. I don't see it as a standalone therapy, but maybe as one piece of the puzzle that could really help some of these patients to have better outcomes. We are also working on potentially using this methodology for some immune-related therapies. And I know Carl, and I think Michelle, you will talk about this next, because that is another way, because then you don't actually need to achieve full coverage. You just need to basically evoke this immune response in close proximity of these tumors. And then that might open up some other doors. So I do think it remains a very exciting technology. I think we see the early studies that it's definitely safe and feasible. And I think now it's on us to really develop this in the right sequence for the patients where the tumors are suitable for such a therapy.
Great. So yeah, as you alluded, I think most families now are clued into this idea that we could harness the immune system to potentially go after these tumors. And so I want to ask Michelle about the development of CAR T therapy for DIPG and potentially cover some of the trials that are open currently and where she sees the future of this class of therapy.
Thanks. Yeah, I think this is an enormously exciting and hopeful area for DIPG and other DMGs. In my laboratory, we, together with Crystal Makel's group at Stanford, have developed a CAR T-cell strategy that targets it's actually a sugar moiety that's present on the surface of DIPG called GD2. It's a again, long and easy to say word. It's a disilloganglioside that we had discovered is present in extraordinarily high quantities on the surface of DIPG cells. And we discovered this again using patient-derived cell cultures and xenograft models that have depended upon these incredible tissue donations from patients and their families. And GD2 is an immunotherapeutic target that is present in other childhood cancers like neuroblastoma. So when we discovered this, there was already a toolbox of immunotherapeutic strategies to go after GD2. And the Makel lab had developed a CAR T cell strategy that had been optimized to try to avoid exhaustion of the CAR T cells. So T cells, when they go after a tumor cell, can burn out. And so her laboratory has worked really hard to develop strategies and to engineer these cells to be able to, have good stamina and persist. And so when we put this particular CAR T cell therapy into mice that were bearing DIPG tumors in the ponds, we saw clearance of the tumors, which was enormously exciting. It was really the most effective strategy I've seen in any of our preclinical models. And just for the audience to understand, CAR T cell therapy is essentially a process by which a patient's own lymphocytes are taken and then engineered, kind of weaponized to go after a particular target. So that the lymphocytes are harvested through a process called apheresis, and then using a virus, you express a new gene that allows the T cell to really home in on one thing, and then you give those cells back to the patient. And so what we saw in the mouse model was that those T cells that are targeting GD2 track to the tumor. They and if you put them in the blood, they track through the meningeal vasculature and infiltrate the tissue and then eliminate the tumor. And the hope is that they would then persist and kind of remain as a living drug within the individual. We've just opened a CAR T cell clinical trial at Stanford aimed at establishing the safe dose of cells and developing the safest way to administer this therapy. I remain really enthusiastic and hopeful about this strategy. Another way that you can give CAR T cells rather than giving them, through the blood is to give them directly into the central nervous system, either into the cerebrospinal fluid or directly into the tumor itself. And so there's another CAR T cell trial open at Seattle Children's led by Nick Vitanza, targeting a different molecule that is present on DIPG cells and administering those CAR T cells into the cerebrospinal fluid. So I think over the next 6 to 12 months as a field, we're going to learn quite a lot about different potential targets for CAR T cell therapy and DIPG, different modes of administration, and hopefully they all work and we can continue to optimize.
Excellent. So we are on our final 5 minutes or so, but I did want to circle back to a concept that has a lot of potential. In the last 5 years or so, we found that another mutation that is very unique to DIPG is in a gene called ACVR1. And Dr. Hawkins, Cynthia, was part of those initial discoveries. And so I want to give her some time to talk about how ACVR1 may be affecting biology, and if she thinks there's potential for therapeutic targeting of that in the clinic.
Sure. So ACVR1 is a receptor that sits on the cell surface, and we found in DIPGs that about 20% of patients will have that protein mutated on their DIPG. It's one of the genes that if you have it, it's there in every tumor cell, or as far as we can tell from doing studies of sort of clonal evolution of DIPGs. So from that perspective, it looks like a very promising target, at least for the patients that have that. It activates a pathway called the Bmp pathway. And so I think when we first found that mutated protein, you think of it as, this is a potential target that is it's specific to tumor cells, because obviously normal cells won't have that, and that hopefully we could have targeted the DIPGs that way. I think now as there's more work being done on how to target that, and I think when there's a big consortium, which is sort of run by a group actually based out of Toronto, but which has collaborators in Europe and in the United States, trying to develop a drug for that, has found that it's actually not easy to develop a drug that will just target that mutant protein. So if you're going to go after that target, you actually need to target ACVR1 itself and the downstream components of that. So I think it's definitely promising, but we'll have to see once we do more testing whether that's going to cause an issue for normal cells, I guess, first of all. And then I would say, like many of the other things we've been talking about today, I think this will be great as part of a combination, unlikely to work just on its own. So I think if we understand a little bit better about exactly how that BMP pathway activation is collaborating with histone mutations and how that's altering the cell intrinsic biology portion, it'll be easier maybe to tell what we would combine that with to be the most effective.
Thank you, Cynthia. So I'm going to wrap up the discussion here. I think this was excellent. I think for a lot of our families, hopefully this can be like a second and third opinion in one in a short video. I want to just say some words about the support of the ChadTough Foundation and other foundations that support researchers like ourselves. So ChadTough Foundation has supported all of us here, and if you look at all of the progress we've made in the last few years, it is because of this sort of community support. I think DIPG and DMG is very crowd-funded, and I think we are only making the progress we can because of the donations and support from the community members. And so for us to continue to get up over this mountain and start to make these improvements, which we all believe we are close to, we're going to need everyone to continue to stick with us. And the donations and support that people make, even the small ones, are tremendously helpful to those of us on the ground. And so I will end it there, but I want to thank the participants here and thank the ChadTough Foundation, and look forward to meeting some of you who will be watching this video or communicating with you and your providers as you look for more information about these tumors. Thank you all.
Thank you.
Thank you.
Thank you so much to Dr. Carl Koschmann, Dr. Sabine Mueller, Dr. Cynthia Hawkins, and Dr. Michelle Monje for taking the time out of their very busy schedules to do this with us. To everyone out there who supports our foundations at ChadTough and Defeat DIPG, I hope this shows the amazing research that you are helping to make possible. And to all the families that are currently in the fight, we're there with you. We promise we won't stop fighting for your children. Thank you so much. And just remember, everyone, we are tougher together.